Okay, it's about 6 o'clock, and today is Wednesday, January 27, 2021. This is Dr. Garais, and this is MED210, meets on Wednesday evenings. Again, if Miss Pritchett, I do see you. Let me write it in. And again, have to state for the record that Zoom is mandatory. And I've also now been informed, so are the laboratories. So if you have a safety issue or transportation issue or whatever issue that you are unable to come to campus, week 8, week 9, and week 10, I need to know about it. And then we could talk offline, and we can also have other alternatives. But I have been informed by my chain of command that student must show at week 8, week 9, week 10. But I do understand if you have safety issues, transportation issues, scheduling issues, please get that to me now. Another thing I'd also like to announce is this, we're rolling out tutor.com. Here's the link. You could also, always ask your professor, but for any other class, especially if the professor is unable to meet your tutoring needs, check this tutor.com out. I'm gonna try it out as well. I just got some training in it, but I'm gonna try it out. I'm gonna pretend to be a student and see how good it is, because the university wants, because many times, you know, since we're a small university, your professor's unavailable or not available at the time that you need them. This tutor.com is 24/7, so it's kind of neat. Try it out. This is week 4, so what's due this week? Week 3 items, which is your task, your discussion, and your lesson 3. And now we're gonna start task 4 stuff. Now, since we're gonna have midterm next week, and those of you who had me before, it'll be the same format. Those of you who haven't had me before, I will be putting the instructions in your announcements right here for next week. And it is a online thing. You don't have to be on campus. It's only week 5 for next week. But it'll be 50 items, multiple choice. And I believe, let me check. I think I already put, click on this. I'm gonna put the Zoom recording link here. So I'm gonna put the Zoom recording link here, and there's already a practice midterm from 2019. So again, not the same exact exam, but so I like doing it so that the student gets a little bit of an idea and then a flavor of what's to come. But honestly, everything from week 1 through week 4, and if it has to deal with identification of a part, anatomy, or how the parts work together, physiology, it's fair game. And at the end of this lecture, I'm going to briefly go over some high value targets and some nice pictures on what you could focus on for the exam. And also a little primer on you know, how to deal with a multiple choice examination. Okay, so let's jump right into it. Let's look at what's in store for us, task 4. Now, this week it is the kidneys, and they are, it has multiple functions, but its main function is to filter out any excess items, anything, because anything in your body that's extra, like water, salt, nutrients, and such, it's considered waste. Okay, anything that goes that's extra should be thrown out. So we're going to be talking about in chapter 25, what are we throwing out? What actually is urine? How do I make urine? Okay, and why do I have to throw it out? And of course, the structure of the internal and microscopic structures of the kidney, namely the nephron and all these little funnels and internals here. This is a cute video. It's okay. This video is, I don't like it. I'll show you a diagram of the Renin, Angiotensin, Aldosterone system, which regulates not only your fluids, not only your salts, but also your blood pressure. And you could see how that actually is all the same thing. Here's some, again, in task 4. You click on your urinary physiology lab. Again, don't do the lab. We're going to have a kidney dissection week 8 or 9 if you come to lab. But there's nice little quick notes here that mirror the stuff that we're about to go over in your chapter 25. I always like these Carolina notes because they're just much simpler. So when you look at it, urinary system, structure and function, kidney, structure and function, goes and endocrine regulation of kidney function, which is this, the renin, angiotensin, aldosterone system. And you could look at this video, but I'm part of the curriculum committee. I already recommended to remove this video. I don't know, it just complicates matters when it's not as complicated as what this video seems to play it out. Oh, we're going to be also talking about the other, we already know the main function of the kidney is to filter out the blood, but now because of this, I already added that the function of kidney is also dealing with your blood pressure. Okay. Well, another thing that your kidney deals with is because kidneys can either retain salts or throw away salts. They can retain water or throw away water. Don't you think it can retain or throw away hydrogen ion, and or it could secrete certain buffers that will keep our blood pH at a certain level, which is around, it's close to 7. It's around, I forgot already. Physiologic pH is what, 7.4, 7.3, around there, right? If you recall, your pH is like 1 to 14. Why am I just talking about it? Let me just review it well, I'll review it when we get to it. But you could now see how important the kidney is, and it not only does filtering of your blood, it does a whole bunch more. So we go into of course, this is our main page, right? And our course textbook right here, and it's OpenStax. So I click on that, table of contents. Then I scroll all the way down to chapter 25. Love the 25, love that number. 2nd Battalion, 5th Marines, always. Okay, had to have that little commercial. Okay, so we have our objectives already, so do I have to read that? No. So let's jump right in. Oh, wait, before we get into urine, I am getting ahead of myself. Now, the kidneys have several functions, okay? So we already know one, which is already the filtration. So we got to ask ourselves, what does it filter? It filters out nitrogenous waste, extra nitrogens. Your body loves carbon, hydrogen, oxygen, and nitrogen. We already know carbon, hydrogen, oxygen, and nitrogen come in the form of proteins. Carbon, hydrogen, oxygen come in the form of lipids. Carbon, hydrogen, and oxygen also come in the form of carbohydrates. And the most important carbohydrate, or simple sugar, that we know and love is glucose, 6-carbon sugar. So we don't need a lot of nitrogens. So we got to get rid of them, and we got to get rid of them in the form of urine. We also get rid of them in the feces as well. So that is the main function of our urinary system. And it also regulates pH, because if it can throw out water and if it can throw out hydrogen ion, then your kidneys can also control pH, right? Which is how acidic or how basic your blood is. And remember, you need to be in the middle. And another thing that kidneys do, they throw out buffers to assure that your pH is well balanced. Another thing that your kidney does that's kind of important is they also secrete erythropoietin. It's EPO, capital E, capital P, capital O for short, right? And it is, what do you call that? um, the kidney sees, well, both your kidneys, they see all the blood. Blood comes in and they filter everything. So let's say, for example, in a 70-kilogram man, 5 liters of blood should go through the kidney all day, every day. But what happens if, let's say, for example, somebody stabbed this 70-kilogram man, and now a liter of that blood is on the dance floor and not in the body? Well, your kidneys detect that there is a drop in not only blood pressure, but it'll also detect a drop in volume. So it will signal erythropoietin release so that our red marrow can make more red blood cells and the red marrow in our bones. Okay, so that's red blood cell production, and the releasing hormone for that, the signal for that, is erythropoietin. Another thing that the kidneys also do and is a part of is part of your vitamin D. Okay, you can eat your vitamin D all you want, but we also get a lot of vitamin D from the sun, but the final synthesis and processing of it happens in the kidneys. So if you look at here, there's a lot of stuff going on for homeostasis. It affects everything. And even though we're talking about like one system, you could see how they're all connected to each other. Okay. So with that being said, let us look at, before we, because it jumps right into urine for whatever reason, but I want to go, before we get into urine, and I'll be quick about urine because you should get that stuff from, what am I making things complicated? Let's look at this. Because I just want to briefly go over who are the players in this particular system. So let's just look at a random picture. So we of course have the main star, that's the kidney. Then we have these two tubes, and there's two of them. And if you look at our patient here, the right one is a little bit lower than the left. Now, you could put in the chat, I'll give you a second, or you could shout it out. Does anyone know why the right kidney is lower than the left? Let's give it a second. Let's think about that for a minute. Like, why is it? Because why would whoever created us, you know, I always quote the space aliens as our creators, so as not to offend any other religions, unless your religion is space invaders. But maybe you've guessed it already. You guys remember there was a huge organ on your right side, right? And the edge of it is around your 10th rib. That's your liver, right? The largest metabolic organ in your body. So that's taking up this much. And remember, this is the right side of your patient. This is the left. So the right kidney is a little bit lower. Now, of course, this whole entire abdomen is covered by your peritoneum. If you recall that from your Anatomy and Physiology 1, especially if you were with me cutting up some pigs last term. Well, the kidneys are so important, and you now know they're very important, that whoever created us put them behind the peritoneum, behind the covering of the your abdomen to protect it. So your kidneys are located retroperitoneally, or behind the peritoneum. The prefix retro means what? Going back or behind. Then you have these two muscular tubes, and they're exaggerated. They're actually very, very thin. And those are your ureters. You have two of them. And then you have the urinary bladder here, which is also a muscle made out of transitional muscular tissue. That means it can be as small as a golf ball, and in a typical 70-kilogram male can be as big as 2 liters. So it can hold a lot of fluid. And then you have your urethra, and then it goes to the toilet. So you have 2 kidneys, 2 ureters, 1 urinary bladder, and 1 urethra, okay? And then goes out to the toilet. So these are our players in the urinary system. So I could easily have this, you know, I don't think I'll make it that easy for you, but I could, you know, if I'm feeling generous, I could just erase this. Is this a kidney? Is this a ureter? Or I could have this picture and maybe exaggerate it, maybe make this a little lower, and you tell me which is right, which is left. And of course, in this, right, this is left, okay? And be careful with this term ureter. Ureter, two of them. Urethra, you only have one, okay? And here's another pretty picture with some letters in between it. And you could see how they're intimately connected to your arteries and veins, and a rather big one actually, your azygous vein and your descending aorta. Oh, by the way, you get a hole in any of this, don't make any plans. You ain't going anywhere. All right. So let's now talk about what does this thing produce. This system produces urine. And what's urine? It could be a multitude of different colors depending how hydrated you are or how dehydrated you are, right? Or sometimes there's even blood in there. And we can all think of a normal situation, especially in our female patient or our female counterparts, that there could be also a blood tinged if they're having their menstrual cycle. But you could see there's a various array of colors, and the color would be anywhere from pale to deep amber. Now, odor is, I don't know who wrote this. It's not odorless. You guys know what pee smells like. It smells like pee, right? And the correct term for a normal odor of urine is called aromatic. Let's, what's this term? Or you could just say normal, but let's be 110% correct here. Now, there could be abnormal smells like mousy, foul. Oh, by the way, you'll know foul. Foul smells like hot fish garbage in the middle of August that's been laying outside for a while. You can even be a couple of feet away from your patient, and you could definitely smell foul. Another one, which is kind of common, but it's really subtle, is for uncontrolled diabetics. Since they have a lot of ketones in their system, ketone is a derivative of acetone. That's why when they urinate, you're going to have a fruity smell. There'll be the urine smell, but then right at the end of it, it's going to smell like a little bit like acetone. Now the volume, again, it's but there should be a regular volume. If your cardiovascular system is working, you should have a regular and consistent volume. pH can be anywhere from acidic to slightly basic, right? Specific gravity. Now, what does that mean? How heavy something is. So all this means is it should be as heavy as water. The standard for specific gravity for water is 1.000. So 1.003 is pretty close to water. That means when you're urinating, you shouldn't have any extra stuff like blood, glucose, proteins. Bilirubin and urobilinogen, they provide, they're metabolites from various things that you're going to learn more in your biochemistry and things of that matter. That's provides the coloring, and also could be also an indication of any red blood cell hemolysis. Now, leukocytes, you shouldn't have any. You shouldn't have any proteins. You shouldn't have any ketones. And remember, ketones are no bueno to the human body. That's a starvation state. Nitrites. Now, you're going to have some nitrogens because that's what we're trying to do. We're trying to get rid of it. But a different form of nitrogens and common form in the nitrites, you shouldn't have that. And of course, blood, unless the only other normal situation is menstrual cycle. And of course, definitely glucose. So this is how I remember it. Anything that's worth, like protein, blood, glucose, that should not, and white blood cells, red blood cells, those things are things that your body needs. They shouldn't be in your urine, okay? And this is the physical, this part up here, and here, this bottom part here, and that's the chemical analysis. And this is the physical analysis: color, odor, volume, pH. Color, odor, volume. And another thing they didn't mention here regarding the characteristics, urine should be clear. If it's cloudy, odds are your patient has a hyperlipidemia. It's probably lipid. It's probably way too much fat. Now, if your patient's diabetic, what are they going to kick out? It's called splay. They're going to kick out glucose, because remember, anything that's excessive or extra or too much is your body considers its waste. So that's what should end up in the toilet. Okay? Urine volume, nice to know, right? But these terms: oliguria, anuria, not good. Polyuria, on the scale of things, not good, most likely diabetes. But oliguria, when you start having, when your urine starts urine volume starts getting low in like 300, 400 range, that's impending kidney failure. And if you have anuria less than 50 cc's or an ml per day, don't make any plans. You're having impending kidney failure. That's a big problem, okay? Because if your cardiovascular system isn't working, or your urinary system isn't working, you're going to have oliguria, then it's going to turn into anuria, then you're going to have kidney failure, and that's never a good thing. And that's why for your future nurses, please do not see vitals as a nuisance, or, oh, that's above my pay grade, or I should be doing advanced things. I hate that. I hate that arrogance, because if you miss this and this, how many times I had patients go south? How many times I had patients die because of poor monitoring? Right, like at 12 o'clock at night, I'm already having reports of a patient with 400, 450 cc's at the end of the day, right? No one took any monitoring, and then at 6 a.m. I have no volume. That's a no-no. That's how you get charges. Okay, so let's look at the parts, and I don't know why they went backwards, but I guess let's go backwards. So the urethra, what's the urethra? And if we recall the picture, that was the picture that goes from our urinary bladder. The urethra is the tube that goes from your urinary bladder to the outside world. Now you could see how the male, well, depending on which male, right? The urethra is much longer. So the odds of any bacteria getting there and reaching all the way in to the urinary bladder, it's not as good. So unfortunately, ladies, who's more prone for urinary tract infection? Because of how short the urethra is and its proximity to the anus right here, right? So that's a nice little formula for urinary tract infection. And remember, do not confuse urinary tract infection with STD. STD is a urinary tract infection due to sexual contact, and there's certain bacteria for that, for those of you who have yet to take your microbiology. But the most common for UTI is E. coli, and that makes sense because the anus is right here. So it's very, very easy for E. coli. And we would like to deal with urinary tract infections while they're still down here. Because if they go up this ureter to the kidneys and have a kidney infection, we're in really, really bad shape. And you could also see, and we're going to be talking about this in week 9, how the anatomy also protects the urethral orifice right here. You have the anatomy of the labia minora, right? The minor fold, and the labia majora, which is the major fold, which protects this. Okay? And of course, here's the vaginal canal. This goes to the uterus. And here for the male, you have, and we're going to, again, just for completion, just so you can take a look at some of these things, of course, testes, and then your vas deferens, and then it all connects here. Now, the really important one is here, the prostate. You can now see how if my patient, right, their prostate starts blowing up, you could see how it can push on this bladder and then like block the urethra, and then you're going to have urinary problems, urinary incontinence, right, and also erectile dysfunction. So that's your urethra. Now moving up, you have your urinary bladder. Your urinary bladder is made up of a whole bunch of muscles, and it's what do you call that? It's a bunch of layered muscles, and it's made out of a specific kind of muscle called goes lined with this stuff called transitional epithelium. Meaning to say is it can be very, very small, and then it could get very, very big, right? And this, in theory, should only be a temporary way station for urine. Now, in theory, when you urinate, the urine should be sterile, okay? But if you let the urine hang out here, you know, you're one of those people like, let's see how long I could go without peeing. Please don't be that person. My kids are that person. They're like, I'm okay, and they're already turning green, right? Because if you leave the urine in here, you leave anything like urine or even just water in a dark, warm place, it's going to get bacteria, and then you're going to get a UTI, and that's no bueno. All right. And you could also see we have sphincters here, right? You can use your imagination, like a circular muscle here that will help close off. But you know what? In the end, when this thing gets big enough, the pressure would be so great that this amount of muscle will win over this muscle, and then you wet yourself. So key things: transitional epithelia, it's muscular. Urine should, this is a temporary way station for urine until you can get to the bathroom, okay? Now, Mcturition is another fancy term for urination, also known as voiding. Now, if it is a muscular problem or it's a nerve problem, then you're going to have some incontinence. And in the case of prostatitis that we showed earlier, it could be a prostate problem. Okay? And you can see all the nerves here, which, by the way, your sacral nerves, I believe it's S2 to S4, sacral nerve 2, sacral nerve 3, sacral nerve 4, they all connect into here. By the way, is the common saddle injury. Any of you ride motorcycles? Nobody? No, I'm the only one? Yeah, okay. Live your life, people, come on, right? So S2 to S4. You break any of this, like you break your lower part of your sacrum, or it's called a saddle injury, especially with motorcycle riders, you're not only gonna have some urinary problems, you'll also have erectile dysfunction. Well, this is female, but if male, ugh, it's messy. It's never good. And that's why I'm not allowed to ride my motorcycle. I had to give it away. Sad state of affairs. Now, let's look at the ureter, okay? So remember, sacral. So if my patient breaks their back, it's going to mess with urination and a lot of sexual function. Not only for walking and all the other things, you can see how the sacral nerves, which they're kind of big, right, innervate the urinary system. Now, what's a ureter? Ureters are those two tubes that lead from the kidneys to your urinary bladder. And if you could see here, they're made out of muscle. And there's the lumen, which is the, the opening, right? So it's smooth muscle. Now, we know that smooth muscle, we can't control it, okay? So it's automatic. And it has peristaltic motion, just like our esophagus. If you recall Anatomy and Physiology 1, you remember how does food automatically go down your food tube or your esophagus? The smooth muscle automatically kind of pushes it down in the same way how when you get the drawstring of your shorts or your sweats and it gets stuck and how you have to push it down like inch by inch by inch. That's essentially how your ureters move urine down. So I don't know why, but when I was in a fraternity, for whatever reason, we made one of the fraternity pledges pee upside down. Don't ask me why. We do stupid things like that. But he's able to pee upside down. And why? Because there will be a peristaltic motion from your kidneys to your ureter. And please do not try that at home. That is stupid fraternity tricks, which is, again, one of my favorite words, no bueno. All right. So that peristaltic motion is automatic. You cannot control it. That's why trying to control your urine, trying to keep it all in isn't going to work. And also, have any of you, like, maybe you went to a music festival, or you know, you're out with your kids or whatever, and you just lost track of time and didn't pee for a while, and then you went to go pee, and then you got all crampy? Well, all that smooth muscle, especially, will start to spasm, like your ureters and your urinary bladder. That's all muscle that you can't control. And if you let it all get stretched out because you refuse to go to the bathroom, you're going to get spasms and it's going to hurt. Ugh, just thinking about it just gives me a shiver. Alrighty, so it's at this point, and it goes because if you guys are got any questions, please you could put it in the chat, and you know me, I monitor it. I will periodically stop, or if you're like, hey, wait a minute, can you go over that part? So you know, so please, that's my public service announcement. Alrighty, so you could see here that are if looking at the kidneys, they're also protected by your ribs. You have 12 ribs, and 2 of them are floating. Did you ever wonder why you got 2 extra ones that aren't connected to your sternum, or well, either directly or indirectly not connected to your sternum, just floating back there, right? Well, it's to protect your kidneys because they're very important. And they said they're going to do external anatomy. Hello? They're lying to us. They didn't show the external anatomy. Well, let me show you the external anatomy. Of course, this is your ureter, right? And let's get another picture. There's probably another picture, but I'm too lazy. Boom. Let's do this one. Okay, the main thing about the external structures of the kidney is, number one, it has its covering, okay? All major organs, or most organs, if not all of them, have a covering to protect it. Now, the kidney shape, you see this is big dent that's in here, right? That dent is called a hilus. In other textbooks, they even call it a hilum. But hilus, hilum, potato, potato, and it does look like a potato, right? That's the indentation that leads inside into your kidneys. And what are the 3 structures? And this is on almost every major anatomy and physiology exam. What are the 3 structures that enter the hilus? And it's important because what if my kidney got ripped out? What 3 major structures will be definitely affected? Well, I got my renal artery, and by the way, it's not colored red. We just call it the renal artery. I mean, color it. Excuse me. We just color it red so that you know it's an artery. You have the renal vein, which is here, right? And you have, of course, the ureter. So this is what happens, right? Blood from your cardiovascular system goes inside, goes in here into your renal artery. Once it goes inside, we're going to be talking about the internal structures. It does its magic, its filtration, and then the clean blood then does what? Go out, okay? Now, after it does its magic, where does the urine go? Goes in the ureter. So renal artery, think oxygenated blood, right? And also dirty blood, or has a lot of nitrogenous waste. And renal vein, colored blue, and deoxygenated blood. That means the red blood cell isn't carrying too many oxygens. It's carrying more carbon dioxides, right? And that's that tube. And these are the external structures and external things of the kidney. Now let's go over, I'm sure they have very beautiful pictures of your internal. Now, how easy is it tonight for you to take this, put this in Microsoft Word, or heck, just look it up. Look up kidney quiz or something where somebody did it for you. Hey, I got a second to show you guys. Let's say I want to study that, right? Kidney anatomy quiz. Hit images. Oh, what do you know? Do you think I could just take this and just practice? How about this one? Take this, practice. How about this one? Take it and practice. Yeah, I could, right? Because you know, what am I going to do? I'm going to have a picture like this. I'm going to erase all this and do A, B, C, D, E, F, G, and then ask what's what, right? So when you look at this, the dirty blood, right, comes in, and then it goes into this layer on the outside. Does everyone see how you've got to use your imagination a little bit? Let's actually look at a real kidney. When you're looking at a real kidney, real, really real, I almost wrote. There you go. Oh no, oh, this is a diseased one. Don't want to look at that one. Do you see how in a real kidney, how like this, like you could see that there's like an outside edge. See that? Does everyone see that? And then you got the inside parts. Okay? So you have an outside and an inside. Well, that outside, that's your cortex. In that cortex, you got like, I forgot how many, 40 million, 100 million, these microscopic structures called nephrons, or functional units of the kidney. And we're going to go over the nephron in a minute. So when the blood goes in, right, that's where it gets scrubbed and cleaned, and that's where all the magic happens. And then you see the rest of the kidney. That's the medullary portion of the kidney. And can you see that it's all it is just funnel? Doesn't this look like a funnel? And then this looks like another funnel, and this looks like a funnel, and this looks like a funnel. Is it just my imagination? Nope. Remember we saw this in Anatomy and Physiology 1, right? When we cut up the little tiny piece of the kidney of the piggies. So you have your cortex here, and that's where your nephrons are located, and it does the magic. It does all the filtering, and then it creates the urine, and then urine goes in here in these big things called your renal pyramids. Then it goes into a minor calyx, which is this mini funnel, and then you got a major calyx, which is a bigger funnel, and then you have your renal pelvis, which is this big funnel behind all of this magic right here, right? And also you have your renal papilla, which are these little finger funnels that connect from the pyramids. And you may ask yourself, then how do all these funnels get held up? Well, if I want to have structure to it, I held them up with a column. Can everyone see that there's a column here, there's a column here, there's a column here, there's a column here. So, and also the columns allow for arteries and veins to get up and through those areas as well. So when you look at it from a simplistic view, cortex, the outer, medullary area or the medulla, the inner funnels. You have funnels here, and the capsule is the covering that I was talking about. Then you have the funnel here, the big one, right? Like a big pyramid. Then you got little fingers, that's your papilla, minor calyx, major calyx, and renal pelvis. And they all end up and flush all that urine all into this ureter. So if you look at it like a story, then what do you call that? It'll be easier to memorize all the things. Like I went from this street to this street to this street to this street to this street. I went from the pyramid through my papilla, my little fingers, through the minor calyx, through the major calyx, through the renal pelvis, and into the ureter. And from this point on, that's my medullary cavity or medullary region. And my cortical region or the cortex is this outer part, and this little covering is the capsule. And that's what a capsule does, isn't it? It covers something. Okay, so we look at a real kidney, right? All we have to do is just take our story and then adapt it to the real thing. I've got a cortex. I have a medullary area. You could see the renal pelvis, And you might not be able to see the papilla, it's really small, but you could see somewhere here, this is a minor calyx into a major calyx, and you have your renal pelvis here, and this is a dissected part of your ureter. Neat, huh? Right? So, and that should amaze you because 24/7, this thing makes urine. As long as your heart is beating, it will make urine. Now, remember the cortical region that we just talked about? Well, in this cortical region, you have all these microscopic things called nephron. This whole thing is called a nephron, okay? So let's look at, let's see if they got a, ooh, here we go. Nice picture here. And let's do it like a story so we can remember everything, okay? Remember we mentioned before when we talked about the hilum, all the dirty blood, right, comes in? Well, this interlobar lobular artery is dirty blood. Then it comes in here, and then it gets into this tuft or this like dust bunny of a bunch of capillaries. Capillaries are very thin. They're only single layer thin, so it's easy for filtration for things to go in and out. And this area here is called your glomerulus. Now, the capsule that's surrounding this tuft of capillaries, your glomerulus, it says here glomerular capsule, it's called the Bowman's capsule, B-O-W-M-A-N. So this guy, I don't know, whenever, figured out that, you know, that's my capsule, I'm gonna call it Bowman, right? So you have your glomerulus and then your Bowman's capsule. It is at this crucial junction where the filtration happens, right? All the extra things that we want in the urine get thrown away. Anything that we need to keep stays in the arterial system. And you could see, wait a minute, there's more arteries. And why is there more connections? Well, it's because this filtration system isn't 100%. This filtration system has two backup systems because it could have messed up. It could have done two things: thrown out something that it shouldn't have. So if it threw out something it shouldn't have, like glucose, like, oh, I threw glucose by accident. Well, there's other points in this system where the glucose can be reabsorbed, okay? So that is absorption. So absorption is your kidney's way, especially the nephron, to pick up something that accidentally got thrown out, okay? Now, let's say, for example, I had way too much salt. Salt. Now, salt should have been thrown out, but didn't get thrown out for whatever reason here at the Bowman's capsule. So somewhere along the line, what's going to happen to the salt? It's going to get secreted. So you have absorption and secretion and filtration. Filtration is the main part, and that happens here at the glomerulus and the Bowman's capsule at this level. And then here at these other levels, that's when you have secretion and reabsorption, right? Those secretion and reabsorption are your kidney's backup plan just in case this filtration system here went a little bit on the wrong side. And remember, secretion is secreting something that I should have gotten rid of, extra or garbage that I should have gotten rid of, and reabsorption is, oh, I shouldn't have thrown that out. I'm going to take that back in. So right then and there, this thing should amaze you because, by the way, with all of our technology, we only can do one thing, this. That big Fresenius machine that you see in the kidney center can only do one of these functions, just this. And by the way, this is microscopic. That big Fresenius machine, I don't think I could lift it with my own two hands. And I am no slouch with lifting despite my big, big gut. All right, so reabsorption, secretion, and filtration. And filtration definitely happens where? Here, at the level of the glomerulus that's covered with the Bowman's capsule. And let me spell that for you. They didn't put it on. Glomerulus is this, and that's the tuft of capillaries, a little dust bunny of capillaries, and it's all, you know, like a big ball, big tangled ball. and your Bowman's capsule. Those are the first two parts, and it is at this level of the glomerulus that is where you have filtration. And then the two backup systems are reabsorption and secretion. Okay? Okay. And of course, let us now go to the other parts. You have the PCT, which is the proximal convoluted tubule. Convoluted just means what? It's just windy. And if you have a proximal convoluted tubule, you have to have a distal convoluted tubule, or a DCT. So you have the PCT here, and you have the DCT here, which is the distal convoluted tubule, and this is your proximal convoluted tubule. Proximal means what? Closer. Closer to what? The action. Right here, the glomerulus. Then you have this big long tube here, and that's called your loop of Henle. Let me write that down so you can recognize it. Now, the loop of Henle, that has the what they call the countercurrent. Just know for your purposes right now, it deals with water and salt. Okay, so water reabsorption and salt reabsorption, and we're going to see a little bit video about it later. So, what are the parts of our nephron? And remember, this is microscopic, and there's like, I forgot how many, like 40 million of them. Who knows? Well, they know. Look, you know what? Instead of me just guessing, let's ask the almighty guru, so I can finally remember it. Yeah, no wonder I didn't remember it. 200,000 over 1.8 goes to 1.8 million, depending. All right, so whatever number I quote, there's a huge range apparently, but they're microscopic, and there's a ton of them, and it's in the cortex region of your kidney, or that outer region of your kidney. So here are the parts for summary. Here's your glomerulus. Here is your Bowman's capsule, proximal convoluted tubule, into the loop of Henle, then to your distal convoluted tubule, and then ending in your urinary duct, which ends into a renal papilla. And we already know about the renal papilla, the little fingers at the end of my renal pyramid. So if you know that story and combine it with this story, you have yourself exactly how your body makes urine. And also, you now know why it makes urine. And here is a better diagram of what a tuft of capillaries looks like. And it's only a single cell thick, and the red blood cells go in there, right? And whatever's on them gets removed or cleaned, and whether it be sugar, salt, nutrients, whatnot. So you could see here that this thing is a really fine, like it's a really fine mesh. It's a really fine filter. So if you've got diabetes and you have this huge 6-carbon sugar banging up against your screen door, it's like throwing a brick at a screen door. So what's eventually going to end up in your urine? Blood and glucose, and that's not a good thing. Okay. Your JG cells. Now, should I talk about your JG cells now? Nah, I'll wait. And see, this is another, I don't know, this is a little craziness with the Renin Angiotensin Aldosterone system. I have a better chart for you guys. I don't like that one. Let's look at, now it goes into pathology. Now, before we leave the kidney, let's look at the loop of Henle. Countercurrent. And Khan Academy is pretty good. You know, I have a thing about Khan Academy, and look, they do NCLEX review as well. And I believe, is this located? I think they have this video. Let me look if they have it in lesson 4. I think they have it in lesson 4. Is this the Khan Academy one? Nope. But I like the Khan Academy one. Okay, so I'm going to take it. This is anything that is. I'm going to take it, copy it, and I'm going to put it in your, because I like this video, but this one, I like the Khan Academy video better. I'm going to put it in the announcements, right underneath your Zoom recording. I'm going to put it right here. Okay. Of course, here's your practice exam for next week. So it's in there. So take a look at this, because for you future nurses, I don't really go into this topic too much, but you future nurses, this is a NCLEX high value topic. And if you want to stay and hang around after the lecture, I can go over the video and we can talk about it. But I would like to focus on our objectives. Now, you could see this thing called GFR. GFR is your glomerular filtration rate. How fast does blood go through your glomerulus? Okay, so in a 70 kilogram male, typically has 5 liters of blood. Okay, so and eventually you're gonna have to know all these volumes and rates and whatever for future training. But just know that there is a specific rate on how fast these 5 liters should go into your kidneys, and that's called the GFR. So if the GFR drops, that means I have a drop in kidney function. Okay. And you can see here, there's pressures that eventually you're going to have to memorize, and it just gets ugly. Okay. Now, here is a nice picture where it just shows you that things can go in and out. And what are some of the things that go in and out? Salts, sodium, potassium, calcium, magnesium. So you could see that the production of urine isn't just nitrogenous waste and water. There's other things in it. And you could see it can also urea and uric acid and ammonia right here. These 3 things, that is the level of nitrogens in your urinary system. So if your urinary system isn't working, wouldn't you see a whole bunch of this inside your blood? And that's not a good thing, and that's called azotemia, and that's essentially when your kidneys aren't working, it's all the poison is getting all backed up, or all the waste is getting all backed up. And you could also see here, hydrogen and potassium, right? The hydrogen ion, we definitely know, deals with acid base. So knowing and understanding these things, and you could see here clearly regarding the loop of Henle, the first part deals with water, and then the second part deals with the 3 salts, sodium, potassium, and chloride. And that's your countercurrent, which is the video that I just put up there. Okay, and here's our and this is a nice video for future reference, but I just wanted you to show that we know that there are specific places that you can have reabsorption, right? Things going back in, and secretion, things that were missed. Okay. And here's some. You don't need to know this for the exam, but again, for future reference, you're eventually going to need to know that, but not for my exam. Ooh, countercurrent. No, let's not talk about that. It's going to get messy. And this is what we mean by countercurrent. Counter means what? Offsetting or off balancing. So one side will be water and the other side would be salts. And remember what we talked about, osmosis and diffusion? you're going to need to know those concepts. And you could see that because of water going out and the salts going in, it creates a gradient of different, not only different pressures and different amounts of salt and water as you go down this loop. And that's how your body knows what salts to pick up, what salts to throw out, what water to pick up or water to throw out. And it's a little bit, I'm super oversimplifying it, but that's what the function of your loop of Henle is. We already talked about the nerve systems. Okay, we're already on the renin, angiotensin, aldosterone system. Now, let's talk about some other hormones before we talk about this big one, RAA, the renin, angiotensin, aldosterone system. ADH gets released as anti-diuretic hormone. Now, anti-diuretic hormone tells your urinary system, do not pee. Anti means against. Diuresis means voiding or urination. So if you have anti-diuretic hormone, it tells your body not to pee. Now, when does it do that? Let's say, for example, you're walking in the desert, okay? And you need that water. So your body is telling your urinary system, please do not pee, please do not get rid of water, so it releases ADH or anti-diuretic hormone, right? Natriuretic hormones do the exact opposite, right? They tell your kidneys to secrete sodium. Natriuresis or Na plus is sodium. Now, wherever sodium goes, guess what? Guess who follows? Water. So natriuretic hormone secretes sodium. Once you have secretion of sodium, what's going to do? You're going to water is also going to follow. Now, remember we talked about before parathyroid hormones. I'm not sure if it's in this term or the class before. We talked about parathyroid hormone and phosphates. Nice to know, but these two, ADH and natriuretic hormones, and endothelin is a vasoconstrictor, okay? Because remember, we're going to be talking about renin and angiotensin aldosterone system. Another thing that the kidney does is also regulate blood pressure. So it also secretes endothelin, which is a powerful vasoconstrictor. So it'll tell your blood vessels to constrict and then increase your blood pressure. Okay. Now, diuretics. Why would I give a patient a diuretic, also known as a water pill? Well, think of it this way. Like blood pressure is the pressure exerted on the walls of your arteries in your blood. You got to think of it like a garden hose. So if I turn up more volume or more water, the garden hose will get really hard and it will have a lot of pressure. Now, increased blood pressure is not good for your body. Remember, your body likes to be in the middle. Also, decreased blood pressure isn't good either. You don't want hypotension. You don't want hypertension. You want to be normotensive, somewhere in the middle. Okay? Now, if my patient is hypertensive, that means they have way too much fluid in their system. What do? I give them a diuretic. They pee a lot, and by a lot, every 10 to 15 minutes. And then that will decrease the urine volume, and then it'll drop your blood pressure as well. We also give diuretics to heart patients because if there's more pressure on the heart to do work, the heart will work harder and then will ultimately fail, and we don't want that either. Okay? So these are some basic strategies that we employ in the medical world. Let us now finally talk about the last thing, and let's look at our objectives just to be sure that we're going over every little thing that we should. So this is task 4. Did we talk about the properties of urine? Yes. Structure and function and how urine comes from the kidneys, right? All the way to the toilet. Yep. Structure and function of the kidneys. Yes, both internal and external processes. And the same thing here. The only thing left to talk about is this right here. Now you could go through this video, which I don't like. How many times did I say that? That's how much I don't like it. I like this picture. Here's my favorite picture. Here. Of course, it's in Pinterest. My arch nemesis. Okay. Now, when you look at this, it seems complicated. You're like, man, how am I gonna? It's a million and two things. Well, look at it again. Isn't it a one thing here, one section here, and then one section here, right? So let's look at this one whole big section. And remember, if you learn it like a story, right? Like that's why when you see things like this and like this is haywire. I love this one because it's just so simple. Wish I had this in medical school. It would have made my life easier. So just like in homeostasis, there has to be some sort of impetus or some sort of stimulus to trigger your urinary system to go do something. So something has to be wrong. So think dehydration, sodium deficiency, or hemorrhage. And in all three cases, what happens to my blood pressure? It's all going to go down. And if my blood pressure goes down, what also goes down? Blood volume. So if I'm dehydrated, I don't have that much fluid volume. If I have sodium deficiency, remember what we talked about? Wherever sodium goes, water goes. So if sodium is leaving my body in droves, what else is going to leave my body in droves? Water. And last but not least, remember that 70-kilogram man that I stabbed? And then about a liter of his, well, did I say I stabbed him? Scratch that. I didn't stab him. Somebody else did. And that's my story, and I'm sticking to it. If you have hemorrhage, what's going to happen to your blood volume? A whole 20% of it's going to be on the floor, right? So it's all of this is going to decrease blood pressure. Wouldn't that be a beautiful, beautiful question? Which of the following situations will decrease my blood pressure? Dehydration, sodium deficiency, or hemorrhage? Or C, or I mean D, all of the above, E, none of the above, right? So now, right off the bat, you got some questions here. So we know this. All this is one big thing, one big idea. So this idea is going to spark this next section. Now, I waited to talk about your JG cells or your juxtaglomerular cells, glomerular. Juxtaglomerular means right on top of or right next to your glomerulus are a bunch of cells. Now, your juxtaglomerular cells, and in slang we call them JG cells, and they're in your kidneys. And guess what? They monitor blood pressure. So if there's any decrease in blood pressure, what's it going to do? This system called the Renin, Angiotensin, Aldosterone system. So what's going to happen? Renin has to be released. So does angiotensin. So renin gets released, and by the picture, you can even close your eyes. Hey, that's by the kidneys, right? In response to a JG cell. And doesn't this look like a J? Just saying. Now, angiotensin, I got a picture of the liver here. Angiotensinogen. Gen means creation of. That means this is a precursor hormone. It has to be activated. Well, somebody activated it, renin. Renin then activated angiotensinogen to angiotensin 1. Now, if you have a 1, there has to be a 2. So if you look at here, you have ACE. That's your angiotensin converting enzyme, and it's in your lung. So 1 will turn into 2 because of this enzyme that's in your lung. And that's this next story in the next section. So if you remember it, like, oh, JG started this, then angiotensin and angiotensinogen helped out for my boy, the liver, right? Then it went from 1 to 2. And then how did I go from 1 to 2? ACE did it, and it was in the lungs. I can ask you a plethora of questions here, right? It goes, which hormone activates angiotensin 1? Renin. What is required? Angiotensinogen. Where's the origin of angiotensinogen? Your liver. Where's the origin of renin? Your JG cells. Where are your JG cells? In your kidney. What activates all of this? Decrease in blood pressure, right? 1,000,002 questions, right? How does angiotensin 1 get converted to angiotensin 2? Oh, ACE. Where's ACE resided? Here, in your lungs. So that was that second section, right? And just like a good concept map, Can you guys close your eyes and you could see this section and this section? So now let's look at this section. Right now we have renin, it goes angiotensin and aldosterone. So somewhere on the line, aldosterone has to be activated. Now, we look at the word angiotensin. Remember your medical terminology powers. What does angio mean? It means blood vessels. Tensin means to what? To tense it out. So what's going to happen to my blood vessels? They're going to constrict. If they constrict, what do I want? Blood pressure. Now, this one, you have the adrenal cortex. Do you see how the artist drew it like an A? Adrenal. Above goes my kidneys. So what's going to happen? It's going to A, adrenal cortex, A, aldosterone, and then what's going to happen? Increased sodium. If I have increased sodium and water resorption, what's going to happen? Increased blood volume. And isn't that what I want? Vasoconstriction and increased blood volume to increase my blood pressure because I started off with bad blood pressure, right? Well, you're dizzy because this is the first time you heard of it. But try looking at it and telling the same story and listening to the same story in pieces. Learn how to draw this part first, then this part, then this part. Now, it rolls off my tongue because this is 30 years of looking at this thing, right? But for you, because something that's this complex, if you break it down in only parts, so this part right here, does everyone get this part that we always start with what? Decreased blood volume, and with 3 situations that need to be changed, right? Then this part, and that's the JG cells, right? Try drawing it on your own. Probably by the 3rd or 4th time you can draw it on your own, you start to, it takes like 3 or 4 times, right? And then you have this part. Now, angiotensin, think angio, vessel, tense, right? It's going to tense up. So vasoconstriction, okay? And this is like, I call this like 3A and then 3B. Then you have your adrenal cortex A, aldosterone is an A, and what do these 2 A's do? These 2 A's will do what? What do I want? I want to increase my blood pressure. So I have to increase my sodium, I have to increase my water, and therefore increase my blood pressure. So I know it's a little bit daunting, but look at it in pieces. And then right after tonight, because in theory, you should have allotted time until like 10 o'clock. And I typically end what, 7:15? Just take just 30 minutes. Or how's this? 15 minutes a day for the next couple of days. And just try to draw it. Try to do the same thing. Okay, so what kind of questions could I ask here? I go, my patient has vasoconstriction of the arteries and increased blood volume. Will their blood pressure be increased or decreased or nothing? Right? Vasoconstriction, squeeze, increased blood pressure. Increased blood volume. Remember the garden hose analogy I made? Squeeze, right? So that means my blood pressure will go up. How can I get my blood volume up? Well, remember, wherever salt goes, water goes. So sodium and water, right? And by all means, this is not an easy thing, but also on the other aspect, this ain't the hardest you'll ever see. You don't want to know what a concept map for neurology looks like. And they have names that don't match to, that's what I hate about neurophysiology. They have names, they only have numbers and letters. And immunology too, that they have numbers and letters instead of, here, at least you have medical terminology that can kind of give you a hint, like angiotensinogen, creation of. That means this is a what? A precursor, right? Now, let's look at the practical aspects of knowing this. If you know the 2 things that give you high blood pressure, do you think you can now start blocking them? Yes? Makes sense, right? So I know that angiotensin 2 gives me vasoconstriction. So don't you think I can have a drug called an ACE inhibitor, which the most common side effect is chronic cough? Makes sense, right? How about this? How about if I block renin or block angiotensinogen? Yep, there are medications that do that. Then I won't have this. How about other medications, right? Other medications that will, like your anti-diuretic. If I have way too much water reabsorption, way too much sodium in my system, what do? I give my patient anti-diuretic. They throw salt out. With salt going out of your system, water will follow. You'll pee every 15 to 20 minutes. And then what's going to happen to your blood volume? It's going to decrease. And your blood pressure will also decrease. So you can see this is all we do in medicine, is we just play with what we already know. We already know the parts, the anatomy, and now you know the physiology on how blood pressure goes. So this is really, really good. That's why I love this. Now, he goes, try to do one of these jobbies. Ugh, yucky. This one I don't like either. That's why I chose that one. This one I like. It's so simple. And I'll put the picture on your announcements as well. All right, let me take attendance real quick to see if it matches up with what I got from the beginning of the class, because we started off with a couple people and now we added a couple more. I got Ms. Brown, Ms. Mandy, who else? The other Miss Brown, Miss Reed, Miss Muna, Miss Munoz, Miss Fox. Let me count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. I count 12. There's 12. We're all golden. So it is at this portion of the show where I'm going to